Okay, welcome everyone to our 2021 Mental Health Policy Briefing. Thank you so much for joining us today. We're really delighted to have you. This presentation is brought to you by the National Alliance on Mental Illness of Rhode Island and the Mental Health Association of Rhode Island. I'm Lori Marie Peixoto, the Executive Director of the Mental Health Association.
And I'm Beth Lamar, and I'm the Executive Director of NAMI Rhode Island.
Thank you, Beth. This event is being recorded and we will share it on NAMI Rhode Island's YouTube page as well as the Mental Health Association's YouTube page. Thank you so much for joining us today. We do not take your time for granted. We know you are all very busy. We hope this is just the beginning of an ongoing dialogue with all of you around the most pressing issues facing our mental health community. If you have a question, at the bottom of your Zoom screen on the lower right-hand side, you should see a hand emoji, which you can raise at any time if you have a question. And we'll also have a period of question, answers, and comments at the end of this presentation as well. So first, Beth and I will tell you a little bit about our organizations. The Mental Health Association was founded over 100 years ago by a gentleman named Clifford Beers, who was born in 1876 in Connecticut. He suffered from major depression and episodes of psychosis, and he spent quite a bit of his life living in asylums. Back then, asylums were horrible and degrading institutions. Patients were literally bound by iron shackles. Some of them were caged. The living conditions were filthy and the asylums were overcrowded. It was a living nightmare for the people who had to live there. So he began to chronicle his experience and he wrote a memoir called A Mind That Found Itself. He published it. The book was read widely across the country, particularly by physicians. He documented the living conditions he experienced and many others experienced living in asylums. He gained the respect of American physicians, and they helped him start a movement to deinstitutionalize people who could live in the community. They also started to reform psychiatric institutions. And these physicians, although they were very sympathetic and respected Clifford Beers, they advised him to hide his own experience with mental illness. They said, you don't want to talk about your own mental illness because you'll discredit yourself and no one will take you seriously. And he said, well, thanks for the advice, but no thanks. I'm going to fight in the open. So that's exactly what he did. He advocated, he shared his own lived experience with mental illness. He founded the National Committee for Mental Hygiene in Connecticut, which later became as the Mental Health Association. And that was the headquarters of our parent organization, which now moved to Virginia. During the movement to reform asylums, he issued a call to all asylums across the country to send in their iron shackles so that they could melt down all the shackles and create a 300-pound Liberty Bell, which still exists today. I've actually rung that Liberty Bell in Washington, D.C. at a national conference. It was a wonderful feeling. And eventually Clifford Beers lived a full life as an advocate, and he passed away in 1943 in our very own Butler Hospital in Providence, Rhode Island. Today, I follow in Clifford Beers' footsteps as a mental health consumer who speaks from her heart and shares her lived experience. I fight in the open. The Mental Health Association is the face of mental health policy in Rhode Island. Our mission is to improve the system of care through policy advocacy, research, and public education projects. That's who we are.
NAMI Rhode Island was founded in 1983, just a few years after its national organization. And the organization in Rhode Island was made up of family members of individuals who are living with serious mental illness. This grassroots organization is dedicated to improving services for persons who are experiencing mental health conditions. Today, we support education, research, and other efforts in order to reduce stigma that's associated with mental illness and to prevent discrimination against those individuals and their families who are experiencing such discrimination. We have programs for families, for individuals, for schools, and for communities in order to raise awareness and to provide support statewide.
Thanks, Beth.
Thank you.
Rhode Island, like many other states in our country, has a broken mental health care system. There are gaps in our continuum of care, and mental health consumers fall through those gaps. 1 in 5 adults lives with a diagnosable mental health condition. It's the most prevalent kind of illness. Yet shame and discrimination keep many of us suffering alone and in silence. Mental illness is a condition of the brain. It is not a moral failing or a character flaw. It is not a choice. I feel very hopeful today. Pop culture has somewhat normalized mental health conditions to the point that young people are much more open about talking about their own experiences compared to other generations. The media has begun to share our stories and highlight the gaps in our system of care. And just having all of you here today gives me a lot of hope that we can change things for the better. So what follows are a few pieces of legislation that Beth and I will tell you about. And we're hoping for your help in moving these policies that will improve Rhode Island's system of care.
So we're going to begin each of these items by talking about the problem that's taking place and a little bit about the statistics that inform this problem, and then the solution, the bills that might be on the table and what those bills will do for folks. So the first is the problem is youth suicide is the second leading cause of death in Rhode Island teens. We have a statistic here that 15.9% of Rhode Island high school students report that they have considered suicide, and 10.5% of those students report that they have attempted suicide. This statistic is based on data that's a couple of years old, and if it is rising with the general statistics, as I imagine it is, then that number will likely be higher with the pressures of the pandemic and other things that youth are facing today. Teachers and school staff are often not equipped with the resources that they need to help students who are in crisis. We do know that mental health education for teachers and school staff has been mandated, but without the budget to support it, there are a lot of schools that are still struggling to make those resources available. And then lastly, we say that youth are afraid to ask help when they're feeling depressed or overwhelmed. As we know, when adults are feeling scared, experiencing thoughts of suicide or suicidal ideation, can only imagine how a young person might feel when they have far less life experience and less resources to turn to. And so the solution for this item here is that there is a House Bill 5353, the Senate 0031, which requires student and school staff training on suicide awareness. That would provide the resources that are necessary. And it also establishes a conflict resolution process between teachers, school staff, and students, as there have been some issues in the past that brought this into the headlines.
Thanks, Beth.
Thank you.
Mental Health Association initiated this legislation right here, and we thank Senator Miller and Representative Craven for sponsoring it. Low reimbursement rates for behavioral health outpatient care are a parity violation. They violate mental health parity laws. And there are dire consequences for consumer when this happens. So we know, according to the Milliman Research Group report, that Rhode Island's outpatient behavioral health providers are reimbursed 23.4% less than their counterparts on the medical side of a plan for doing similar types of work. And the consequence for this is that providers are less likely to participate in an insurance company's network, which means we have a smaller pool of providers to choose from when we are a mental health consumer. It means that providers who are being reimbursed so poorly are going into the red and can literally document how much they're in the red based on which insurance company you're talking about. It means that consumers like myself have to go on a long wait list to see a psychiatrist or to see a psychologist or therapist who has expertise in my particular mental health condition. It means consumers, according to the Milliman Research Report, are 4 times as likely to go out of network for mental health care compared to primary care visits. And that in Rhode Island specifically, 50,000 or 27.9% of adults go without treatment when they need it. Would we ever tolerate 27.9% of cancer patients going without treatment? Of course not. People would be protesting in the streets if that were happening. But this happens every day when it comes to behavioral health conditions and behavioral health treatment. So this is a real problem in Rhode Island, and we're trying to find a solution to this problem by incrementally increasing the reimbursement rates for public and private insurance for outpatient behavioral health providers over a 5-year period. And this would bring them up to parity with their counterparts on the medical side of the plan. So both sides would be equal. It also requires the Office of the Health Insurance Commissioner to assess the rates every year to make sure that they're being increased at a rate on parity with medical providers. And in doing so, we hope that this will attract new providers into our in-network provider directories and make it easier for consumers to find a provider when they need one.
Another problem that we're experiencing is that about 47% of Rhode Island youth have experienced an adverse childhood experience, often referred to as an ACE. An adverse childhood experience is a term that we use to describe abuse, neglect, trauma, or other occurrence that takes place in people under the age of 18 and is therefore linked to increased incidence of depression or anxiety, PTSD, substance use, suicide, and poor school performance and overall wellness. So we can reduce the effects of these adverse childhood experiences by interacting with youth using a trauma-informed model in schools. As you can see, more than 45% of US children are exposed to at least one adverse childhood experience. We're a little bit above that national average, and more than 1 in 5 children have 2 or more adverse childhood experiences in which those major impacts are seen. So exposure to these experiences can impact a child's ability to learn and succeed in school, among other negative impacts. If we were to implement trauma-informed school models, this would then support every student's health and as well as every student's school potential. It would also make for a safer environment for not only the students, but the school staff and the teachers as well. And there are 5 principles that guide the trauma-informed model in schools: safety, choice, collaboration, trustworthiness, and empowerment. Training would be provided to all school staff and teachers in order to make sure that that model was taking place. The solution in this case, therefore, would be the House Bill 5936, which would establish the implementation of those trauma-informed practices in schools throughout Rhode Island.
Thanks, Beth. Housing is mental health. Housing is recovery. Housing is food security, education, and employment. In fact, SAMHSA says that the 4 pillars of recovery are housing, health, community, and purpose. In Rhode Island, as you know, we have a housing crisis like many other states in New England. According to the National Low-Income Housing Coalition, in Rhode Island, tenants must earn $17.51 per hour to afford a 1-bedroom apartment in Rhode Island. And according to the 2020 Housing Works Rhode Island Fact Book, more than 67% of families who rent in Rhode Island earn less than 80% of the area median income, less than $66,000 for a family of 4. Many families are slipping into poverty. People who are poor are twice as likely to have common mental health conditions, such as depression and anxiety. In fact, low-income populations are twice as likely to have depression specifically. So we are encouraging all of you to please support Budget Article 6, which would fund the creation and preservation of affordable housing in Rhode Island. We did have a major victory this year, and I want to say thank you to all members of the General Assembly for passing the Fair Housing Practices Act this year, which prohibits landlords from discriminating against lawful sources of income, including housing vouchers. Many people with disabilities who receive SSI or SSDI benefits also receive housing vouchers. And when landlords discriminate against housing vouchers and other lawful sources of income, it makes it very challenging to find affordable housing. So this is a huge victory in Rhode Island, and it should make finding housing easier for people with disabilities. So a very big thank you to the General Assembly for doing this for Rhode Island. It's really important, and we're so grateful.
The next item is the need for mental health services in schools. So we know that by about age 15, all of lifetime cases of mental illness begin to demonstrate themselves, and 1 in 5 children aged 6 through 17 has a diagnosable mental health problem. Older teens who are struggling with depression are more than twice as likely to drop out. And suicide, as previously mentioned on another slide, is the second leading cause of death in youth ages 10 to 14. So we have, in addition to the trauma-informed schools that we mentioned prior and the youth suicide that we mentioned prior, this particular bill, House 5067, is looking for Medicaid reimbursement for school mental health services. By providing said reimbursement to those providers, it would make school mental health services kind of on par with the health services that students can get outside of school. And as we know, reimbursement rates, especially under Medicaid, are complicated for providers. This would help providers to establish themselves within the schools and would also compensate them at a fair rate, which right now is not taking place. Many school mental health providers are not receiving Medicaid reimbursement or are not eligible to receive Medicaid reimbursement. This would also provide early intervention processes and programs for students, which would save money in the long term in the system, because then crises would be avoided and those students would be getting consistent care.
Thanks, Beth.
Thank you.
In Rhode Island and across the country, about 15% of inmates live with schizophrenia, schizoaffective disorder, major depressive disorder, bipolar disorder, brief psychotic disorder, and substance use disorder. Mental illness itself is not predictive of criminal behavior. In fact, it actually increases the likelihood of being victimized. But we do know that people with untreated serious mental illness are overrepresented in our prisons and jails. The annual cost to incarcerate one man in high security prison is $195,000 per year in Rhode Island. Incarcerated adults have a higher than average prevalence of chronic conditions such as infectious diseases and mental illness. And Medicaid and Medicare do not cover the cost of health care for inmates or medications for inmates. Those costs fall to the state of Rhode Island. It costs more to house an inmate with mental illness compared to other prisoners because they tend to stay longer in prison and need additional services. Their disability makes it harder for them to conform to prison rules, often resulting in being sent to isolation, which is debilitating and more expensive than living in the general population. About 50% of all inmate suicides are committed by inmates with serious mental illness. So the solution to this problem was proposed by Chief Judge LaFazia. She is asking us to establish a mental health treatment court in Rhode Island to divert vulnerable Rhode Islanders with disabilities from incarceration. This legislation creates within the district court a dedicated calendar offering treatment and sentencing alternatives to eligible defendants deemed to suffer from serious and persistent mental illness. And this will be known as the mental health treatment calendar. It's an important step in the right direction, but it must also be noted that we need to invest in developing the full continuum of care in Rhode Island, because having a diversion program is wonderful, but where are we diverting people to? We need to invest in alternatives to prison and hospitals. We need housing options, we need treatment options, we need community services and support. There's not just one fix for this complicated problem. We need to tackle it from various angles, so that people with disabilities won't fall through the cracks and end up incarcerated or hospitalized or living in a homeless shelter. Neither of these bills has been heard yet. It's Senate Bill 678 by Senator McCaffrey, House Bill 6025 by Rep. McEntee. Neither has had a hearing yet, but we're hoping that they will be heard. And if you can help pushing for a hearing, we'd be very grateful for that.
The next problem to discuss is that of Eleanor Slater Hospital. The civil commitment facilities are at risk of closing. If you have been reading the paper or watching the news, I'm sure this is an issue with which you are likely already familiar. Eleanor Slater Hospital is part of Rhode Island's continuum of care, which offers a variety of settings from the highest to the least restrictive need for all patients. And as we know, as advocates, there will always be people who have such complicated disabilities that they will require this level of care that the hospital provides. To eliminate the option of Eleanor Slater Hospital would directly contradict the intentions of the Olmstead requirements. When we deny any access to care, it puts vulnerable people at risk of increased emergency room, hospitalizations, homelessness, and incarceration. The Olmstead requirements, the ruling language does not actually require all people to be deinstitutionalized. Sometimes the hospital setting is the least restrictive setting, as it is the only place where that person can get the care that they need and would likely otherwise be at risk for greater impacts on their health or even their lives. Sometimes the Olmstead requirements seem to be deliberately misinterpreted to support the case of closure to hospital settings, and sometimes those nuances are just confused. But in order to be clear, Olmstead looks at a full continuum of care, and eliminating Eleanor Slater Hospital or any other setting would be to eliminate a piece of the system that is needed. So the solutions that we are looking to are that the General Assembly should provide oversight and accountability in order to restore public trust. The situation up until now is that it seems to be creating a general message to the public that perhaps not all patients' rights and needs are being considered by proposing the closure of Eleanor Slater. Eleanor Slater Hospital must be funded. The facilities need to be brought up to code. Not all aspects of those facilities currently are, which was some of the reason for the proposed system redesign. And the civil admissions, which have been closed for several years right now, I want to say about 6 years, and readmissions, which have been closed for about 2, need to be reopened to patients. We're also looking for transparency around the patient discharge evaluation process, which had not previously been made public. Care level criteria by which those patients are being evaluated. In many cases, it's been said that those patients no longer meet hospital level of care, which many advocates disagree with. And also more training is required on how to bill Medicaid, as much money is being left on the table, where we could be billing Medicaid as a state for patient treatment in Eleanor Slater.
Thank you, Beth.
We have a hand raised, Lori. 2.
Okay. Let's see, Judy Sweeney.
Yes. So could you tell me what the difference is, but what is you've changed the thing, but a civil admission and readmissions, what is the criteria for that? What does that exactly mean?
Sure. So civil admissions were those admissions for folks who were entering Eleanor Slater Hospital not by way of incarceration or arrest, people who just were going into the hospital as civil patients. And initial civil admissions, we've been told, were discontinued around 2016, if I recall correctly. Readmissions, we're talking about readmissions when we're discussing patients who had been in the hospital and then were discharged into either home or community settings. But then when they went into those settings, for whatever reason, that new living situation failed and they were unable to get back into the hospital, even though that was where they had been living for some time. Those readmissions have been halted about 2-ish years ago.
Wow.
And we had another hand. You're welcome.
Was it Charlie who had a hand raised?
Yes.
I didn't want to talk about this issue in particular, so if you want me to wait till later, I can wait.
Oh, sure, Charlie, whatever
Sure.
you prefer. Okay,
Thanks.
well, if there are no further questions about Eleanor Slater, we can move on to the next topic. Thanks, Beth.
Sure.
So this is a perfect segue into talking about what an Olmstead Plan is and why Rhode Island really, really needs an Olmstead Plan. The United States Supreme Court ruling, known as the Olmstead decision, noted that compliance with the Americans with Disabilities Act could be achieved if a state could show that it had a comprehensive working plan for people with disabilities. And it had to show that the plan put forth steps to deinstitutionalize people who could be deinstitutionalized. So far, 26 states have created Olmstead plans and 18 states have published strategies, although they don't call it an Olmstead plan, but 7 states have neither. And Rhode Island is one of those 7 states. We are sharing company with Florida, Tennessee, Idaho, New Mexico, South Dakota, and Washington, D.C. So we are in the minority of states that doesn't have any kind of a plan or a strategy for how we will help to deinstitutionalize or prevent the institutionalization of people with disabilities. A living, comprehensive Olmstead plan, you can think of it like a roadmap for the state as a means of ensuring that people with disabilities have everything they need in order to live in the most integrated setting of their choosing, permitted by their disability. We say living Olmstead Plan because it's supposed to be renewed every 5 years in perpetuity. So each 5-year cycle begins with a statewide needs assessment of our population, looking at people with intellectual and developmental disabilities, people with serious persistent mental illness, people with physical disabilities, older adults, and youth at risk of institutionalization. So we do this statewide needs assessment, we look at our population, and then we assess the supply and demand of housing options, treatment options, community services and supports, placing a premium on community input to this assessment process. So the community gets to have a say in this assessment. Then a plan is drafted to help the state to begin to address the most pressing needs of these populations. A good plan puts forth funding streams, federal and state funding streams to actually pay for the things that we need. So people with disabilities, when we have a good plan, people with disabilities should be able to move up and down the continuum of care as their conditions improve or worsen over the span of a lifetime. It should be fluid. So when we talk about readmissions to Eleanor Slater Hospital, that's what we should have ideally, is that if my condition improves and I can live in a less restrictive setting, the state should help me do so. If my condition worsens at some point later on, I should be able to go back up to that more restrictive level of care as needed, and it should be fluid. So every 5 years, we conduct a statewide assessment. We see how the population has changed over those 5 years. We look at supply, we look at demand, and we just it's a roadmap. We get what we need by planning ahead and doing it in a smart, methodical way. So how do states get Olmstead plans? Well, many states have been sued by the US Department of Justice, and that is not ideal. That is not what I want to happen, because once the Department of Justice steps in, they take over and they'll tell you what your state needs, and they'll draft some kind of a plan for you. And I think Rhode Island knows best, for Rhode Island, and we should be able to have full control over our plan. It's also very expensive to be involved in litigation, and that's money that could be put toward housing options and other services in the community. So we really hope that the state does not get sued. The other ways that states get plans, one is through governor's executive orders, and then lastly through a legislature, where the legislature can pass legislation creating an office of Olmstead implementation. Minnesota is a great example of that. If you Google Minnesota's Olmstead Implementation Office, you'll see a spectacular example of how a state's doing it really well. And so there are different ways we can go about getting an Olmstead plan in Rhode Island, and we hope you will be part of it. So an Olmstead plan would fund the following things: a variety of supervised and supportive housing options for people with disabilities, affordable housing for people who live independently with SSI or SSDI benefits and housing vouchers, home modifications, educational and employment supports. There are a lot of people who could be getting an education or gainfully employed if they only had some extra support. But because they don't, they might be stuck in a day program or stuck at home in isolation. And of course, the consequence to the state, aside from the human rights issue, but the consequence to the state and to the federal government is that they're receiving benefits, where they could be less reliant on public assistance if they were able to be gainfully employed. So an Olmstead plan would account for transportation options for people with disabilities, assistive technology, durable medical equipment, the full continuum of treatment options, so residential, partial hospitalization, outpatient treatment. It would look at community and home-based services, workforce development, criminal justice reforms to divert people with disabilities from arrest and incarceration. And then also it looks at policy, legislative, and regulatory solutions for people with disabilities. How can we improve the lives of people with disabilities? How can we ensure that their civil rights are being honored? Before I move on, we have a question.
Are there any legislators currently who've expressed an interest in sort of leading the charge on this one, or have started anything? This is exactly what I'm looking for.
Well, we would love to partner with you to get this done. Senator Louis DePalma has expressed an interest. Senator DePalma has been a fantastic champion for people with disabilities in Rhode Island. That's not surprising that he would have an interest in this, but we are just beginning talks and meetings with Senator DePalma. He has asked me to testify in tonight's hearing on the budget for the Executive Office of Health and Human Services.
Oh, go ahead.
And he wants me to raise the topic of funding an Olmstead plan in Rhode Island. So I will be testifying tonight in Senate Finance. But we would welcome all support from members of the General Assembly, from community advocates, from people who have disabilities or people who know people and love people with disabilities. This is an all hands on deck advocacy effort. Yes, I see a question from Alana DeMario.
Hi there, thank you. So this is Senator DeMario, and I actually have been speaking with Senator DePalma, and he has, just regarding the previous question, he has actually initiated the formation of a disabilities caucus within the General Assembly so that we can pull together legislators who are committed to this type of work and make sure that we're kind of all rowing in the same direction. So that's not up and running yet, but that is something that we're really interested in being able to have a coordinated effort on.
Senator DeMauro, thank you so much for joining us today, and thank you for letting us know about that really exciting development. And please consider the Mental Health Association at your service. We are happy to help in any way that makes sense to you.
Absolutely. Thank you.
So we'd like to close by reminding us that doing nothing is not free. We may think that not investing in housing options and community services and all of these other things is helpful to our budget because it keeps costs low. But the reality is that if we're not paying for these proactive measures up front, we're paying for other expenses down the line. So left to fend for themselves, people with disabilities will often become homeless, will often have contact with the criminal justice system and end up incarcerated. They might also spend time in homeless shelters, spend time in emergency room departments and hospitals, even people like myself who live with major depression, and I've had significant episodes of depression in my lifetime. But without access to outpatient treatment, I might have ended up in the emergency room department. I might have ended up in an inpatient facility or a residential treatment facility. But because I've had access to a therapist and medication when I need it, I can avoid those crises, I can avoid a crisis and those more costly levels of care. And aside from the cost factor, we improve patients' lives, we improve their health outcomes when we invest in preventing a crisis, when we address an illness early on and intervene at the first symptoms of an illness. And it's not just behavioral health care. You can think about, would we rather help someone with symptoms of a heart attack and get them to a cardiologist and on the right medication, or do you want to ignore them and create obstacles so they can't see a cardiologist and then they end up in the emergency room with a heart attack? I mean, which do we prefer? I think we would all agree we prefer to treat symptoms early on. There are better patient outcomes and lower costs in the end. So that's what we just wanted to leave you all with, this mantra that I repeat wherever I go, that doing nothing is not free. It may feel free in the moment, but we pay for it in the end one way or another. I see a hand up from Rep. Ruggiero.
Hi, thank you, Rep. Ruggiero here. And I just want to really thank Lori and Beth for your presentation. Mental health is so very important. And I wanted to kind of circle back, if I may, on the legislation that my colleague, Rep. Portvian, put in, the 5353, which I have a co-sponsor, also the school staff training on suicide awareness. It's the Nathan Bruno, Jason Flatt Act. And that is really, really important legislation, that we're working very hard with your help and your support. And I just want everyone to know that your advocacy really makes a difference. And we cannot do this policy without your help. You cannot do good policy without good data. And we rely very much on your work. So I just wanted to take a minute to say thank you for everything that you're doing. And we're here as your partner as well to help get some of these really important policy issues over the goal line. So thank you for today.
Well, thank you so much, Representative. Your words of encouragement and support mean a lot to us. And please always tell us how we can be helpful. And if we should be looking at something that we're not currently looking at, draw our attention to it. Let us know you need our voice, our support, and we will rally the troops for you. So I'll just, so what can you all do to push this mental health legislation and policy work forward? If you are a member of the General Assembly, thank you so much for being here today. Thank you for your interest in these mental health policies. And thank you for all you do for Rhode Island at the State House. You can support these bills. And as I was just saying, please let advocates know how we can support you. I track about 100 pieces of legislation each session. And sometimes I have an intern who might be able to help me on testifying, but I can't testify on everything of interest to, of interest to us. So if there's something that you feel could really use an extra boost from us, just let us know, and I'll be happy to rally the troops for your legislation. NAMI and Mental Health Association have newsletters. And if you go to our websites, you can sign up for our newsletter and you'll be kept abreast of what's going on, not only with the organizations and what we're doing in the community, but often our policy priorities as well. We also have Facebook pages that we encourage you to follow. If you are a community participant here today, maybe you're an advocate, maybe you're a mental health consumer, or you love someone who has a mental health condition, please participate on our Advocacy Day, which is Thursday, the 29th. There is a policy, a handout of this information on our website, and you can print off all of these pieces, all of these bills and talking points, and talk to your elected officials about this legislation. So that's another way of staying involved with us. I see a couple of hands up. Charlie?
Hi, I'd like to thank you for doing this, because NAMI and the Mental Health Association have been a big part of the Mental Health Recovery Coalition of Rhode Island. And I will definitely, if I can get a link, send this out to the Mental Health Recovery Coalition of Rhode Island email list. Also, I just want to add that the organizations that do this work, it's important that we keep supporting them. And there is an additional organization that's been heavily involved, and that's the Oasis Wellness and Recovery Centers of Rhode Island, which currently is really struggling to keep going financially. And I'd like to encourage everyone to support Oasis and NAMI and the Mental Health Association, so that all these advocacy and support organizations, because we not only do advocacy, we also have support, and especially during COVID, that's important that we keep going and provide the support that people need, which our members have said have saved lives, reunited them with their families, kept them out of the hospital and more. Thank you.
Thank you, Charlie, and thank you for all you do at Oasis. I refer people to Oasis all the time. So we really appreciate the work you do in the community, and you definitely are saving lives. Larry Wilson.
Hi, Lori. I just want to thank both of you for this enlightening presentation. I'm new to the whole mental health programming and its shortfalls and whatnot. So I found this very helpful. My question is, and I have a son, as you know, Lori, who is suffering with mental health issues, bipolar issues, and borderline personality disorder, and so forth. So it's a struggle. My assumption is that it's the marginalized communities, Black and Brown, that probably are affected more so, affected disproportionately by the shortfalls in the mental health field program.
Yes, most certainly. Sorry, there's an echo. Do you hear an echo?
No.
Okay, sorry about that. I heard an echo. That I agree with that statement. I think there are a couple of reasons. Number one is I think historically there's been a lack of trust among people of color with the medical establishment, and for good reason. I think it's understandable. Mm-hmm. And so there is, I think, also because of that lack of trust and lack of interaction with the medical establishment, I think that there's an increased or maybe extra stigma in communities of color, where they are less likely to seek treatment when they do need assistance. I think another problem is that people of color are underrepresented in our behavioral health provider pools. So we'll see far fewer people of color who are therapists, counselors, psychologists, and psychiatrists. And I think that must make it more difficult if I'm a mental health consumer to trust and bond with someone who doesn't share my life experiences or my culture or maybe my language. And so that can be a barrier to accessing treatment. When someone doesn't click with a therapist, it's not a good fit, then the therapy is not effective. And so one of the things we're hoping with our behavioral health provider reimbursement legislation is that it will increase the rates and so hopefully attract new providers to insurance networks who would otherwise not want to participate in a network because they don't want to be exploited. And hopefully if we can end that exploitation, we can increase the diversity of our provider pool. I'll also say that the Mental Health Association received a very generous grant from the United Way of Rhode Island to help establish a diversity, equity, and inclusion program at the Mental Health Association. And part of what we want to do is give partial scholarships to Rhode Island College graduate students in the schools of social work and the mental health counseling program to students of color so that we can help build the pipeline of students becoming the next generation of providers in Rhode Island and hopefully supporting and attracting diversity in our provider pool. So we'll be partnering with Rhode Island College to distribute those scholarships in the next 2 years. And as I said, it will be for graduate students at RIC who are students of color in the fields of social work and mental health counseling to support the future generation of providers.
And I know that you've established a brand new advisory council. I'm a part of that to deal with some of these DEI issues and issues that face the marginalized communities, Black and Brown. So I look forward to working with you. Thank you.
Thanks, Larry. Great to see you.
So just lastly, in closing, we wanted to share all of our contact information for you to be able to stay in touch as we advised. So again, we would welcome and invite you to participate on the 29th in our Advocacy Day. If you're looking for additional information and to join either or both of our newsletters, you can use the contact information on the screen, beginning with the NAMI Rhode Island website. You may email me directly. And also, if you are interested in the Mental Health Recovery Coalition of Rhode Island newsletter, as Charlie mentioned previously, you can send an email to info@namirhodeisland.org to be added to that email list.
Thank you. And you can see Mental Health Association's website as well. And on our homepage, there's an area to sign up for our newsletter. If you have any questions, you can feel free to reach out to me with my email address. I'm also happy to share my cell phone number with anyone who may need that. And now we open up the floor to questions, comments, and dialogue from all of you.
Judy.
So I have one more thing that just came to mind when you were talking about the grant to help students, encourage students to go into this field or to doctors and psychiatrists and social workers to get into this field. I've also noticed that a lot of the people who work with people with mental illness, like CNAs, just don't have, some have a lot better training than others, let me put it that way. And they're the ones who are often with them 24 hours a day. They're the ones who are right there all the time. And I think it would be really helpful if there were some kind of program that would increase the kind of and improve the training for people who are at a lesser level of responsibility, maybe, but not really, because they're the ones who are with the patients all the time.
That's a really good point. The training should be taking place all across the spectrum of care through all the different providers that are out there in the community. I know that that's come up quite frequently, and I've heard anecdotally, though I don't have any statistics to support this, that folks that are on that end of the support staff are oftentimes the ones who can't be pulled away from their day-to-day work in order to do this continuing education, and they're looking for those opportunities. So I think it's up to the facilities that employ them to try and figure out a balance in order to provide opportunities for them.
I had a question in regards to 2020 statistics. I mean, we all know that COVID has made mental health issues substantially worse. So I was just curious if, I'm assuming the statistics aren't even in yet to reflect how much worse 2020 was for the nation, as well for Rhode Island, but for the nation as a whole. I think we're going to see a bit of a lag with some of those statistics coming in, but I think this is a wonderful time to really hit home, and I will definitely do my part on the 29th and contact my reps. And just wanted to say thank you so much for holding this forum for us to learn more and to be able to advocate more for the folks in our state that need the most mental health support. So thank you very much.
Thank you. I do want to make a quick point to what you just alluded to there. There, of course, are not statistics yet for 2020. We'll be wrapping that up. I'm sure it'll take at least a year to come out with some really viable statistics. But I can say just offhand that NAMI National has made mention of the fact that in the past, the helpline, the two top topics, say that 5 times fast, were in the past bipolar disorder and schizophrenia that they had questions regarding. And it changed within the first few months of the pandemic to being depression and anxiety. So we are definitely going to see a rise in those incidents based on situation around the pandemic. Absolutely.
Thanks, Beth. Karen Jeffries, you've had your hand up. Hi, Karen. Are you muted, Karen? I don't hear you.
Sorry. Thanks, Laurie Marie. Thanks, Beth, for doing this. My name's Karen Jeffries. I'm with Horizon Healthcare Partners and BH Link. I just wanted to say I threw in the chat because I wanted to urge folks to check out the states. So all states got a FEMA grant to do mental health and substance use support for people related to COVID. And so BHDDH got one of those grants, and they have a whole program called Pause RI. They have a website. They are working with providers in the state to try to really provide supports for folks who are struggling, obviously because of COVID related issues. So I threw the link to the website in the chat.
Thanks so much, Karen. Thanks for all you do at BH Link as well.
Thank you.
Any other questions or comments? Okay. Well, thank you so much for giving us your time today. We really appreciate it. We hope this was helpful to you. And as I said in the beginning, we hope that this is just the beginning of an ongoing dialogue. Please consider Beth and I at your service to help move these pieces of legislation and policies forward. We want to work with you to get this done for Rhode Island. And if you're a community member, also, we welcome your feedback as to how our organizations can be responsive and can help direct you to the right resource you may be seeking. So let us, please keep talking with us and let us know how we can be helpful. Beth, do you have anything to add?
No, again, just thank you for joining us today. I hope you will contact your legislator if you're a community member on the 29th and ongoing. If you're looking for tools on how to share your story and you either weren't able to or weren't available this morning to join us for NAMI Smarts, reach out to me using the contact info from the slide, and I will be happy to help you tailor your story into either meaningful contact or perhaps even testimony that could be used at a future hearing. So thank you all, and thank you for all the positive comments that are coming through in the chat. We appreciate it.
Well, thank you, everyone. Have a wonderful day, and happy May is Mental Health Month.
Absolutely. Thank you very much.
Thanks,
Bye-bye.
everybody. Bye.
Thank you.
It's just reading the comments.
Me
Good
too.
job, you guys.
Thank
Hey
you.
Karen, how are
Appreciate it.
you?
Good job. That was awesome.
Oh my
Thanks.
goodness. There's always a glitch with Zoom. Like I know I messed up at one point, but that's because I tried to click on the chat to see, just in case someone was saying, hey, Lori, there's a technical problem. And I was like, well, maybe I should make sure there's no problem, no emergency going on. And then I don't know why, but it interpreted it as